you, and thank you for Bayport for having me. Can you hear me up the back? Yeah, great. Thanks for having me speak tonight. It's really great to be back and to be amongst friends, and just going to share with you some of our experiences that we've had with this dressing. And of course, you know, over and over again we talk about the evidence, and I just want to draw your attention to these documents. If you haven't read them, you should if you're practicing in wound management. And it's from these documents that you start to question about what's happening in practice. So, of course, the principles of wound infection, and that's where we're looking at Sorbact. How come we have this dressing that sat on the shelf, and as Terry said, for all those years, yet we've not done a lot with it? And I started to think about that, and where does it fit in the shopping cart? But if we go back and we think about infection, and we have to look at the person that's more likely to get infected, and so the principles around wound infection is looking at the immune capability to withstand infection, looking at the number of microbes, and certainly looking at the species of bacteria. Yet we know this product is capable of collecting lots of different species. It's not targeting just one. And so thinking about that, we can also look at the prophylactic use of this dressing product as well, and it can get a bit expensive when you have just-in-case dressings. And so you want to be able to make sure that you're putting something on the shelf that you can afford. When you read through these documents, you can look at the person who is more likely to get infected. And so as Bill said earlier, and Terry has repeated, that we look at understanding their ability to fight infection, how do we get the food, water and oxygen to the cell? Is there a problem with their nutrition? Is there a problem with their hemoglobin? And so this is stuff that you know, but the importance of that medical history. And then we look at the environment. Well, what's that all about? And you could broadly speak about the environment as in where are they located and what are the impacts about them more likely to get infected, or how did the wound occur and what was the environment like? Are they using aseptic technique? How are they storing the dressing? So all of these things come into the equation. Well, where I was from, we had patients coming to us from a range of different environments, but we all had a hand on them trying to prevent wound infection in these patients. And the levels of education were certainly different across all those sites. And understanding the wife that usually looked after the husband and the self-care and how you teach them not to put bleach on the wounds and so forth, and then the acute care and what's the priority of the care, and it may be get them to theatre and get them back and get the bed vacant, and how much of that are we looking at surgical site infection, or is that the problem of the infection control officer? And I've had the absolute joy in the last 12 months of working in residential aged care facilities. Well, hasn't that opened my eyes? And you know what? They know melanin really, really well. And I'm starting to teach, and I think if we do anything, can we get that off highly exudating wounds, we've done a great job. Independent living, we're getting all these different areas of funded care in wound management. But the area that I'm going to share with you is community care when I was working in the community. But just looking at the wound itself, have we got a product that is specifically designed for this wound, or the feet with fungal, or the legs that have a whole range of bacteria? Do we take silver? Do we take iodine? Which product works best? And then we have the questions about, well, what's a covert and an overt infection? How do we work out when we start to use an antimicrobial and when we don't? And if we're struggling with those questions as clinicians, what's happening to the everyday nurse that has wound management as part of their portfolio but they're not actually specialising in it. How are they going with this stuff? And so it can be really complex. And when we look at if you can describe a covert and overt, and by the way, I love those names because I think about covert operation and overt. So, think about that when you're thinking about, and this is the same wound that just went pear-shaped. And when would you use an antimicrobial dressing in that case? Well, if I put this to the team of nurses I worked with, I can tell you I would have a whole array of different answers. Do you resonate with that? Yeah, okay. So then the same as the treatment of this. Now this is a typical wound. We know we can't see biofilm, but this is the wound that I say to you is possibly got biofilm in it. Yes, we've used this slide before and none of us had seen each other's slides before tonight. So I think this is amazing that we're all on that track. And so biofilm, and Bill talked and so nicely talked about the platonic and then the how these organisms get together. But the area that I'm really interested in is looking at the cell proliferation and how they're starting to communicate with each other. I think that that's where we need to look at when we talk about Sorbact. So I looked at this chart and I thought, well, what's already out there in the evidence that has told us where these ingredients are already working when we look at biofilm? And I've put Sorbact in green because I think the further I read into this, this is where it's acting. Now, I'm not saying this is my opinion. This is not in the evidence yet. But I liked that, Bill, you mentioned about the quorum sensing and how they communicate with each other. We know in the evidence that that is where honey is working. And so it's a question that I'll leave you with that one, and let's watch that space. So these products that I've put up there, they're really important because I would say to you, if you're looking at chronic wounds and you're using normal saline, you're 20 years behind. We have got better products now. And so we need to be looking at what breaks this down. We know we have to prepare the wound to receive a dressing. So we've got antimicrobial confusion. That's what I want to say to you tonight about my presentation. Okay? I'm not clarifying it for you, but we do. So what works when? When do I use an iodine? When do I use a silver? When do I use a microdiacin gel? And when I think about this, and where does me-salt and the high salt solutions fit in? So it's important stuff that we get clarified. So this is the best way. Just think about it, say a little prayer, and hope you get it right. You could do it that way, but I'm going to say to you, this is what we were guided by before because I said so, and this is what you'll do. Betadine and Milton, they always had it right. There was no confusion. But now we've got these nurses, these problem-solving, clinical decision makers that are assessing, making a clinical decision, and then I hope they're using documents such as this and looking at how they're assessing the wound and determining what needs to go on that wound. So the Sorbact project came out of this confusion, and what we did was we wondered whether we pulled everything off the shelf in one centre and we replaced it with Sorbact. And we wondered whether that would make a difference. Would it go, would we have more wound infection? Would it remain the same? And we could monitor this because we had an electronic medical record. 8-week project. And so we had 16 nurses involved, there were 45 patients. We looked at this and guess what? They didn't get any worse. We had some improvement there. We had 31 clients had antimicrobials. We only had 5 patients out of all those patients that could not use Sorbact. But what that did was the nurses had to problem solve and justify why they had to use another antimicrobial. They just couldn't use another antimicrobial, they had to justify it. So this was the trial result. came out that Sorbact should be the first-line treatment. Wound infection didn't increase. As I said, 60% of the clients, the wounds improved or they healed. 40% antimicrobial product expenditure was reduced by 40%. So there's the cost saving. Take-home message from this presentation, again, I'm repeating as my previous colleagues have said, you must improve wound cleansing to receive an antimicrobial product. Consistency in product selection, and there's less confusion. Problem-solving approach if you're going to use another product. Do no harm, go green wound care. Cost-saving opportunities exist. Thank you.